topic, which is timing and dosing of micronutrients for optimal metabolic response by Deacon Moses Kinywa, who is a nutritionist at Kenyatta National Hospital with massive experience in various areas, such as the surgical aspect, medical, and pediatrics. Welcome, Paul. Without further ado, I'd like you to also, as you take in and listen with the presentation, let's also key in some questions in the Q&A section, which will respond later. Thank you so much. Welcome, Moses.
Thank you very much, Sarah. As you've heard, my name is Moses Munene Kinywa. I'm a deacon of the New Apostolic Church and a registered nutrition and dietitian, currently specializing in special surgery and critical care. Our topic today, as you've heard, is timing and dosing of micronutrients for optimal metabolic response. And for this presentation, I will be focusing on the clinical approach, mostly that we use at our hospital. So without further ado, I will start. So our objectives today are threefold. We are going to understand how macronutrient timing affects metabolism and outcomes. We are also going to review evidence-based dosing in different clinical contexts, and we will also explore interactions and delivery strategies for these micronutrients. We apologize for the start. Thank you. As we have said, our objectives are threefold. We are going to understand how micronutrient timing affects metabolism and outcomes. We are going to review evidence-based dosing in different clinical contexts and delivery strategies. Now, timing influences factors such as gastric pH, transporter availability, and hormonal levels. And this is a reason why we are saying that timing and dosing influences absorption, bioavailability, and tissue utilization. All these affect nutrient uptake. In clinical pharmacodynamics or clinical pharmacokinetics, we demonstrate that the same dose of micronutrients can have very different effects depending on the timing and food co-ingestion. An example, vitamin D. Its bioavailability is increased by taking it with high-fat foods, and iron absorption is also maximized when it's taken in the morning due to lower hepcidin. What does it mean? It means that when you time or dose your micronutrients based on how it is absorbed, how it is transported, or based on cofactor hormonal levels, then you are able to meet your therapeutic goals and help the patient. Another reason why we are supposed to time and dose these micronutrients is that it prevents toxicity and efficacy. Numerous studies have shown that oversupplementation is not benign. An example is Kien in 2014 discovered that excessive iron leads to mucosal damage. In particular, long-term use of zinc at over 100 milligrams per day competes with copper absorption, leading to a deficiency we are calling an iatrogenic deficiency that minimizes or reduces the efficacy of any iron supplementation that you're doing. Another reason why we time or dose these micronutrients is to optimize metabolic and immune responses. So, we give. When we give the nutrients is also as important as what we give and at which time. Correct dosing ensures adequacy without toxicity. Timely administration, especially in acute settings like sepsis, can modulate oxidative stress and immune activity. So in the next slide, we are going to look at the metabolic basics that enable us to understand how to dose these micronutrients and at what time to give these micronutrients. If you can see on the slides, there are like 3 points of the different micronutrients that we're going to look at. Of course, there are other types of micronutrients, but those are the 3 types of micronutrients that we found heavy evidence of in the science. And we are saying that there are different mechanisms of absorption. Water-soluble vitamins are generally absorbed in the small intestines and are not stored extensively, which makes it making it a regular intake as a critical strategy in optimizing the delivery of these micronutrients. Fat-soluble vitamins require bile acids and dietary fat for optimal absorption, which means that when you're giving these fat-soluble vitamins, the presence of a heavy fat meal is important to increase the absorption of these micronutrients. For example, when you supplement vitamin D, the science tells us that vitamin D absorption increases by over 50% when taken with a high-fat meal. On the other hand, vitamin B12 requires intrinsic factor and its absorption decreases in atrophic gastritis or when the patient is taking metformin or PPIs. In contrast, vitamin C is absorbed via active transport, but is quickly excreted when taken in excess. So what this means is that due to this differing absorption, water-soluble vitamins require an environment that enhances active transport and reduces loss through urine, while fat-soluble vitamins require that you give them with dietary lipids for proper absorption. In the second point, you're saying that absorption is influenced by food, pH, and transporters. For example, vitamin C enhances iron absorption, while gastric pH influences the uptake of vitamin B12. for the technical errors we're having. We are apologizing, but I will continue. I am hoping everyone can hear me. What we are saying is that these micronutrients have differences in solubility, absorption, and excretion rates. We were looking at the absorption of vitamin C and how it requires the absorption of iron and how it requires vitamin C for it to be optimally absorbed. Excretion rates differ between vitamin B12 and vitamin vitamin C. So while vitamin C is rapidly excreted, B12 can be stored for the liver for years, which reduces the risk for deficiency despite dietary inconsistencies. So which means that when you are supplementing vitamin C versus vitamin B12, vitamin C is required promptly, while vitamin B12 it can be given over a period of time. So in the next slide, we are going to look at the different clinical timing examples that research has shown to improve patient outcomes and also enhance absorption of these micronutrients. So timing must align with both pharmacokinetics and the clinical condition of the patient. For example, when you take iron with vitamin C in a fasted state, it significantly increases absorption as a result of gastric acidity and enhanced solubility. Iron exists in two forms. There is heme iron and non-heme iron. Non-heme iron requires acidic conditions for optimal absorption, and vitamin C reduces ferric iron to ferrous iron, which is more bioavailable. So that is the reason why we are saying that you're supposed to time your vitamin C when the patient is in an empty stomach, and give time your iron supplementation when the patient is in an empty stomach, and give it hand in hand with vitamin C to enhance absorption. Calcium is better tolerated and utilized when taken with food. Calcium absorption is regulated by vitamin D and parathyroid hormone. It competes with other minerals like magnesium, zinc for absorption, and taking it with food enhances its solubility and uptake via active transport mechanism in the duodenum. As such, calcium should be given with meals, which makes the patient more comfortable because they are not experiencing GI upsets, and it enhances the bioavailability of calcium. Vitamin D, on the other hand, is fat-soluble molecule, and it requires dietary lipids for mycelial formation, which facilitates absorption in the small intestine. Studies have shown that if you give vitamin D with a high-fat meal, it increases the serum levels significantly compared to fasting intake. Fasting intake means taking it while you are in an empty stomach. So when you compare fasting intake and when you're taking vitamin D with a high-fat meal, the absorption rate increases significantly to levels that are almost the same. When you look at vitamin B complex, vitamin B1, B6, and B12 especially, they act as enzymes in metabolic pathways, including adenosine triphosphate production and neurotransmitter synthesis. So taking vitamin B12, B6, and B1 early in the morning aligns with what we are calling circadian rhythms, which optimizes cognitive function and energy metabolism throughout the day. In particular, when you're talking about circadian rhythms, These are is a phenomena that has been recently studied, whereby they've studied the body's patterns in terms of hormonal production, where they're saying that in the morning, hormones that are produced by the body are majorly aimed at improving cognitive function and preparing the body to metabolize energy throughout the day. As such, when you give these vitamin B complex vitamins that you're saying are part of coenzymes in metabolic pathways of energy production, then when you give them in the morning, it means that you've prepared the patient to handle all the metabolic stresses that they might experience throughout the day. We will continue looking at the different timings, and this time we are going to look at timing in disease states. In particular, I will focus my attention on burns and neuro injury, surgery, or wound healing, and in renal disease. For those who have encountered burns or sepsis, know that acute metabolic disease stress increases micronutrient requirement due to losses. For example, in exudates with burns patients, and what we encounter is an increased turnover of most of the nutrients that the patient is taking. So in severe burns and sepsis, severe burns and sepsis trigger what we're calling a hypermetabolic state, which increases oxidative stress and systemic inflammation. Vitamin C acts as a potent antioxidant, scavenging reactive oxygen species and supporting endothelial integrity. When you give vitamin C, it's also prudent that you also give zinc, which is essential for your immune function and tissue repair, playing a critical role in DNA synthesis and cell proliferation. As such, when you give vitamin C as an early dose in sepsis and burns, what we are seeing is that there is an improvement in patient outcomes, and and better wound healing. Vitamin C is also supposed to be given hand in hand with thiamine, which we're saying is critical for mitochondrial energy metabolism, reducing lactate accumulation via pyruvate dehydrogenase activation, and improving cellular respiration in critically ill patients. Recent studies in 2017 have shown that an early administration of vitamin C and thiamine together can reduce vasopressor use and ICU stay. This means that we as nutritionists have reduced patient stay in the hospital, and that has also improved the rate at which the patient's wounds are healing. Surgical trauma and wound healing in particular, post-op, require enhanced collagen synthesis and immune support. Vitamin C, as you all know, is a cofactor for what you're calling proline hydroxylase, which is an enzyme essential for stabilizing collagen triple helices, ensuring proper tissue regeneration. So when you give vitamin C and thiamine together, what you realize that the granulation and epithelialization of the wound is accelerated, and the wound closes faster, and it reduces the infection, the risk of infection. In the second point, we're talking about timed B vitamins and magnesium, especially in what you're calling neurodegenerative conditions. And when the patient has these conditions, they they exhibit oxytoxicity and neuroinflammation. So what happens when you give vitamin B6, B12, and folate in the morning, as we have talked about, based on the circadian rhythm, what happens is that it supports cognitive function and neuronal repair. Magnesium regulates NMDA receptor activity, preventing calcium influx that leads to neuronal apoptosis and oxytotoxic damage. And that is the reason why we are saying that in neuroinjury, time your B vitamins and then give your magnesium in the morning so that all these micronutrients are absorbed optimally, and they will be able to help you improve therapeutic outcomes. In renal disease, phosphorus timing is crucial to prevent hyperphosphatemia and associated complications like vascular calcification and secondary hyperparathyroidism. Latest research suggests that dietary phosphorus intake is supposed to be limited to inorganic phosphorus that is found in processed. We are supposed to limit inorganic phosphorus that is found in processed foods, as it is absorbed almost completely. Instead, we are supposed to give organic phosphorus that is from plant, and it has a lower bioavailability, almost 40 to 60%. And then also give what we are calling phosphate binders that should be taken with meals to bind dietary phosphorus and reduce absorption. Calcium-based binders should also be timed carefully to avoid excessive calcium intake. So there are different types of phosphate binders, and some of them contain a lot of calcium. So when you're giving phosphate binders, make sure that you are watching the amount of calcium that you're giving this renal patient. As we know, in renal disease, some levels of renal disease, we give what you're calling dialysis. So timing your supplementations based on when the patient is taking their dialysis can actually help you improve the outcomes of the patient. Serum phosphate levels tend to be higher post-weekend due to interdialytic intervals. This is the time taken between one dialysis and another. So when patients come on Friday, they do dialysis. They stay on Saturday, Sunday. Monday, you will realize that their phosphate levels will be higher as compared to other days. So adjusting phosphate binder doses based on dialysis schedules might help maintain optimum levels for these patients. So what are some of the dosing strategies that we can employ to improve these to improve the patient's metabolic status? There are several strategies. Number one, it's important to understand prophylactic versus therapeutic doses. Dosing must reflect the severity of deficiency or metabolic demand. Prophylactic dosing is designed to maintain adequate micronutrient levels and prevent deficiencies in at-risk populations, such as pregnant women or individuals with restricted diets, like we find in renal patients. On the other hand, therapeutic dosing is used to correct deficiencies or support recovery in disease states. So the main difference between prophylactic dosing and therapeutic dosing is that therapeutic dosing helps us recover in disease state, but prophylactic dosing is supposed to prevent deficiencies for high-risk populations. And these dosings are different even when you check guidelines, nutrition guidelines all over the world. Here in Kenya, we give vitamin D prophylaxis at 600 to 800 international units per day to improve bone health, as compared to a dosing of 50,000 international units weekly for 8 weeks to correct severe deficiency. As such, I implore everyone to understand that the patient's condition is what tells you on whether to give prophylactic dose or a therapeutic dose. So if a patient has a severe deficiency, then what will help the patient in particular is giving a therapeutic dose as opposed to a prophylactic dose. Then there is a concept that we are calling loading doses. These are doses that are used rapidly to achieve therapeutic levels, particularly for fat-soluble vitamins with long half-lives. Vitamin D is an example of them. Vitamin D is necessary for severe deficiency at 50,000 international units weekly for 8 weeks. This is because it bypasses low intestinal absorption and ensures adequate serum levels of 25 OHD levels. This approach, based on pharmacokinetic principles, where we are giving initial doses to compensate for delayed tissue saturation and slow metabolic conversion. For those who have not heard me properly, I mean that loading doses are supposed to be given IV. You give 50,000 international units 1 week, then the next week you give 50,000 international units IV. So that we bypass all those barriers in the intestines and to ensure that we have an adequate serum level. Then there is what we call it blended versus divided doses. Water-soluble vitamins such as vitamin C require that you give them in divided doses. This is because vitamin C is absorbed quickly and excreted quickly through the kidneys. So when you give high single doses of more than 500 milligrams milligrams per day, it results in saturation of intestinal transporters, leading to diminished absorption and increased urinary losses. Dividing these doses of vitamin C can help you optimize plasma levels and bioavailability by maintaining steady concentrations throughout the day, thereby helping you achieve what you had aimed, which is reducing oxidative stress and support immune function. Now, when you are dosing these micronutrients, you are supposed to be careful not to surpass toxicity thresholds. These thresholds are detailed in our guidelines, and we're saying excessive intake of certain micronutrients can lead to toxicity due to accumulation of in tissues or disruption of metabolic pathways. As an example, a chronic high dose of vitamin A of more than 10,000 international units per day can cause what you're calling hepatotoxicity and teratogenic effects due to it being stored in the liver. Similarly, when you give excessive amounts of iron, more than 45 milligrams per day, it can increase oxidative stress, leading to gastrointestinal distress and potential organ damage. So, understanding toxicity threshold is crucial for balancing efficacy with safety in the clinical practice. So, in the next slide, we are going to use to look at some of the typical doses of these micronutrients as we've seen them. In this slide, when you look at it, it gives dosing considerations based on clinical status of the patient. The patient has burns, and so, as you said in the previous slides, we give vitamin C, zinc, and selenium. to improve wound healing. And then for critically ill patients, we are supposed to consider giving parenteral multivitamins if enteral route is compromised. And then for renal patients, restrict fat-soluble vitamin A and adjust vitamin D per CKD-MBD guidelines. So we must interpret serum levels cautiously, especially when you are doing monitoring, and adjust for inflammatory redistribution of dilutional effects. Now we will turn to what you're calling iatrogenic factors that includes drug-nutrient interactions that we are supposed to consider when we are giving these micronutrients. So pharmacologic agents can alter nutrient metabolism via multiple mechanisms. PPIs can elevate gastric pH, reducing absorption of vitamin B12, non-iron, and magnesium. As such, when you are supplementing either of the nutrients, always consider whether the patient is taking PPIs or not, or space those micronutrient supplementations away from the PPIs. Then, when you're giving diuretics, drugs that we are calling diuretics, loop and thiazide diuretics can enhance urinary excretion of magnesium and potassium. Handle the same case with, as we've said above, space them so that we do not have enhanced excretion of these micronutrients. So for those who are asking, PPIs means proton pump inhibitors that are basically prescribed for patients struggling with gastric acidity. Then anticonvulsants and vitamin D can cause folate deficiency. Long-term anticonvulsant therapy with phenytoin, carbamazepine can induce hepatic cytochrome P450 enzymes, which accelerates metabolism of vitamin D and folate. So this can lead to reduced serum levels of vitamin D, increasing risk for osteomalacia and impaired folate-dependent methylation pathways affecting DNA synthesis and neurologic function. Other drugs can cause chelation or competition effects. Certain micronutrients compete via shared transporters. For example, calcium inhibits iron absorption by competing for divalent meta transporter, while zinc competes with copper for intestinal uptake via the ZIP family of transporters. So chelation effects can also occur with medications like tetracyclines, which bind divalent cations and reduce bioavailability of these micronutrients. So when you're also timing or dosing these micronutrients, you're also supposed to consider delivery routes, which is the route by which you will give these micronutrients to the patient. Micronutrients can be delivered via oral routes, which is the most recommended route, but sometimes it is limited due to failed GI function or reduced mucosal integrity. So for patients that cannot tolerate intake of these micronutrients through the oral route, parenteral route can also be used. And the choice of route is pivotal in ensuring that effective micronutrient repletion in critical care settings happens adequately. And always remember that parenteral routes is always reserved for patients that cannot take any food or medicine per oral, or have malabsorptive states such as which requires restriction of intake, or they are not compatible or stable. So as you're giving these micronutrients, it's important to monitor and evaluate the patient. And one way of monitoring the patient is by use of biomarkers, what we are calling 25-OHD, which gives the serum levels of vitamin D. So biomarkers provide objective measures of micronutrient levels and metabolic function. Serum 25-OHD is the gold standard for assessing vitamin D status and can reflect both dietary intake and endogenous synthesis. Then ferritin serves as an indicator for iron stores. Serum zinc levels can fluctuate with acute phase responses, which necessitate functional tests such as alkaline phosphatase activity or for better evaluation. Then other ways of monitoring can also include the functional status of the patient, such as wound healing or immune markers. Clinical outcomes can provide great insight into micronutrient efficacy beyond serum levels. Wound healing rates reflect adequate vitamin C and zinc status, as both are essential for collagen synthesis and epithelial regeneration. When you decide to use functional status to monitor and evaluate, remember that immune markers such as lymphocyte proliferation and cytokine profiles indicate the impact of micronutrients such as selenium and vitamin A on immune function. Periodic labs and clinical review is what will help you determine the duration and reassessment of the patient status, so as to determine the timing or dosing of these micronutrients. Micronutrient therapy, in most cases, requires periodic monitoring to avoid deficiencies and toxicities. Vitamin D supplementation in particular should be reassessed every 3 to 6 months to ensure optimal levels without hypercalcemia. And then iron therapy should be followed up through ferritin and hemoglobin measurements to confirm efficacy while avoiding iron overload. Zinc supplementation can be monitored to prevent copper depletion due to competitive absorption mechanisms. So in a clinical case example, for a patient who is a 45-year-old male with 20% total burn surface area, which is a measure we use to assess the surface area of burns for patients, what micronutrients and doses and timing will you prioritize? So in this patient, what we will do, immediately we will, according to the guidelines, we will initiate an IV vitamin C at 1.5 grams every 6 hours for 72 hours to attenuate oxidative injury. Then we will also give zinc, 50 milligrams elemental per day, per oral or IV, to enhance re-epithelialization of the wounds. Then we will give thiamine at 200 milligrams per day IV, support carbohydrate metabolism. Then we can consider, based on the patient's condition, we can consider selenium at 100 to 200 micrograms per day. Then titrate the micronutrients based on renal function, wound healing progress, and lab monitoring. So Based on the clinical case example, we've integrated nutrient kinetics, timing, and clinical endpoints to tailor the patient's requirements for micronutrient therapy. As a summary, timing and dosing can impact efficacy as much as the choice of the nutrient. Micronutrient therapy must be timely, targeted, and tailored. Use clinical condition to guide your strategy, then monitor for effectiveness and toxicity, and make sure to individualize your plan. Thank you so much, ladies and gentlemen, for listening to me. I will now welcome questions, experiences, or further resources. Thank you.
Thank you so much, Moses, for taking us through this interesting topic. Yes, most of the time as nutritionists and clinicians, we have thought about much Onesimus for joining us today. He's asking, can vitamin C and zinc be administered in wound management, such as in cuts and wounds as a result of road traffic accidents? Moses, yes, thank you.
Sorry for the technical error. What I'm saying is that as I have said, vitamin C and zinc can be given for patients who have experienced trauma, which includes patients who have gone through an accident. And what we have said is that vitamin C is critical for avoiding toxicities. It's also critical for wound healing. It's also critical for wound epithelialization and granulation. Zinc also, they have similar roles, but for zinc in particular, it improves immunity. Yes, so for these patients, it is crucial that they receive vitamin C and zinc supplementation.
Yes, and also in this regard, it will also be very important for us not only to focus on the micronutrients, but also to focus on the macronutrients as well. So it's a combination of the two. So in this regard, especially we know that also protein is very essential and also energy, so that we promote anabolism, so that we promote wound healing. So yes, thank you so much, Ayura Keruba, for joining us today. So she's asking, she's very interested in the topic, and she's asking where can one get these micronutrients? Are they sold as singles or combined? For example, can one find them over the counter as a multivit supplement, or can they help?
These micronutrients are available in our pharmacies as single nutrients or in combination. It all depends on the goals that you have. If the patient does not exhibit micronutrient deficiencies for other nutrients and you're only interested in zinc, then it is possible to get zinc as zinc sulfate, I think, from our pharmacies. And so if you're interested in giving micronutrients as a whole, for example, like we've said, vitamin B complex micronutrients, you can find them as a combination. and you can be able to give the patient and improve their outcomes.
Yes, and especially for patients who have, for patients who are outpatients, it would be important for you not to give very high doses, especially if you're not monitoring them often. So if it is an outpatient who you are actually prescribing what is it called, the micronutrients, it will be very, very essential for you to give in smaller doses so that you avoid toxicity. Because also you have to remember that most of the foods you should also prescribe, apart from supplementation, you should also think of prescribing foods which are actually rich in the same. So it is not only that we particularly embrace supplementation only, but we do it as a deficit of the recommended dietary allowance of the same. And we also include food. So it will be very essential for you to monitor as often as possible so that you do not get toxicity. Thank you. So there's also someone else who's asking which laboratories can actually test for micronutrients in Kenya. So it means people are actually very interested in the same. So yes, and where and at what expected cost, I think, okay, they are various laboratories, even here in Kenyatta, we do test for micronutrients, but now it depends with what exactly you want to ascertain, like ferritin levels we do test, vitamin B12 we do test.
Yes.
Yes, so it depends with what is your particular interest based on how the patient is presenting. So it is, you cannot find all the biomarkers or all the micronutrients being tested in one particular area, but the ones that you can outsource, you can also outsource them from this big major laboratories from outside. Yes, so various facilities, even in county hospitals or in national hospitals or in referral hospitals, they are there based on what in particular you actually want to test, because you cannot test blanketly. You have to test based on how the patient is presenting and their diagnosis. Yes. Alex, thank you for joining us. Please kindly.
Thank you very much, Moses, for this insightful presentation. And the next question is from Helen Wagoi, asking, could you briefly come again on micronutrient dosing in clinical context? Kindly share the slide again. Okay, Moses, I'm not sure whether you can be able to flip that. Meanwhile, he fixed that. We have Monica Muchoma. Thank you, Monica, for joining. Monica has a question. What is the recommendation for micronutrient supplementation during active infections? The question is about recommendation for micronutrient supplementation during active infection. Okay, meanwhile, we address that. We have our own mentor, Edna Warendo. Thank you for joining. The positive comments about well-researched topic. And we have Anonymous at B also with a question concerning what is the best form of magnesium to cater for all nutritional needs. I think for now we can pick those ones so that our speaker today can be able to respond, and also the panel members.
There's someone who has asked about key micronutrient recommendations during active infection. No? The recommendations are broad and there are many, but some of them we've already talked about in this presentation. One of them is vitamin C that acts as an antioxidant and supports immune signaling. It's supposed to be given it's supposed to be given at around 500 to 1,000 milligrams. And we've talked about distributing those doses for vitamin C. Another recommendation is vitamin E, which is also an antioxidant and protects our cell membranes. Give at around 100 to 200 international units per day. but make sure to be careful not to give in excess because it can impair immune response. Then another recommendation is zinc, iron, selenium, whose deficiency has been known to be common in viral infections. And then there is also vitamin B complex. We've talked about it in regard to it, to their role in energy metabolism and antibody production. Give at 100 to 200% of RDA, especially during fever or catabolism.
Okay, yes, thank you so much for that. So the other question, we are yet to project the slide that Monica was, okay. There's someone who asked about the Helen, thank you so much for joining. She was asking whether we can come again on the clinical, on the micronutrient dosing in the clinical context. Yes, we have shared the slide.
Helen, as you can see from the slide, we've only included a few of the disease states that we can we've only projected a few of the disease states that we can supplement these micronutrients. They are numerous more, but these are the ones whose evidence is overwhelming that the supplementation of these micronutrients can greatly improve outcomes of the patients, and that includes burns, wound healing, and sepsis. Wound healing includes all types of wounds, including cuts, burns, or any other type of trauma.
Okay, yes, thank you so much for that. There's one question here from okay, this anonymous attendee is asking, what is the best timing for administration of IFAS, iron and folic acid supplements in pregnant women? So yes, we know that iron and folic acid supplements are very important, especially to prevent the neurogenetic malformations, such as spinal bifida. Yes, and it is very important to know, for us to know and identify whether there is a timeline of the same, whether it is important for them to take with meals or after meals, or should they take them early in the morning based on the whatever was shared earlier. So yes, Moses, thank you so much. Answer the same.
The best timing for giving IFAS supplementation in pregnancy, as you know, it's supposed to start as early as soon as the pregnancy is confirmed. And the best time to give it is after meals, preferably in the morning or midday, which can help reduce side effects, which most patients complain about. For folic acid is in the morning with or without food.
Thank you so much. Thank you so much, Virginia, for joining us today. She's currently seeing the increased need of vitamin C in dermatology patients. What could be the doses of the same in adults for vitamin C?
Vitamin C dosing is given based on the patient's condition and vitamin C is given based on the patient's condition and levels, trauma levels. What I mean is, for example, if for burns patients, they have what you're calling TPSA. So for any other trauma, there are levels of assessment, and mostly for adults, I've seen it's between 500 milligrams per day to 2,000 milligrams per day.
Okay, thank you. There's also another question. Thank you for joining us, Haspa. Are there clinical markers to use before prescribing micronutrients in wounds, e.g. type and extent of wound, or is it safe for prescribing low doses of the micronutrient in all wounds?
According to the guidelines, micronutrients are given based on type and severity of the wound. For anyone who is more than 20% TBSA, they're supposed to receive IV vitamin C in the acute phase in burns management. And the dosage is based, as I've said, is based on the extent of the wound, the age, and the weight of the patient.
Thank you so much. Thank you for that. One last question from Madam Morento. Thank you for joining us today. She's asking, what is the role of multidisciplinary team approach in timing and dosing of micronutrients? Yes, now in this regard, it will be very, very important because especially as nutritionists, we work hand in hand with both the clinicians and the nursing team. So in this regard, it will be very important because we have seen that some of the doses, especially in parenteral, some of the doses that require parenteral route, they need to be prescribed by the clinicians or the physicians or the surgeons. So it would be important for you to inform them that this is the requirement, that the recommended dietary allowance for this particular patient based on their diagnosis. And then again, the clinician will actually be able to rate on the T sheet, and then the nurses will be able to administer based on your recommendation. So if you recommend that the doses should be prescribed and be administered during in the morning or in the afternoon with meals, then you clarify that with the nursing team, and then we will optimize the intake or the utilization of absorption of nutrients of the same. So that would be one aspect. The other aspect will employ Alexander to tell us something of the same.
Actually, that is it, because when you're managing patients, you cannot do it in silos. We have to have a multidisciplinary approach so that you can be able to have a holistic view in terms of various clinical aspects of the patient, and so that there is no bit that is missed out, and also to maximize the efficacy in terms of whatever the dosage that is being provided. I want to thank you for this presentation, because many of the times micronutrient aspects in clinical setting largely has not really been well catered for, and these are very insightful presentations, knowing that when you talk of hospital food service for long-term patients who are in clinical setting for 1 month, 2 months, with challenges that we all know in terms of inpatient feeding, I think it's a high time to rethink and see how we can be able to address micronutrient deficiencies with a better approach than before, because often macros, apart from protein, most of the times we find macros are not the issue, but micronutrients, which are very key in terms of recovery. Most of our patients and even studies have indicated that there is a challenge in terms of addressing this. But what we have seen in this presentation, also the dosing depends on different conditions in respect to kind of patients we are managing.
So thank you so much for joining us today. It was such an interesting topic, and we hope to see you then next month. We will share the next topic with you in the course of the month. Thank you. Have a good afternoon. Have a good afternoon. Thank you.